Hi, I'm Dr. Glen Iannucci. I'm a pediatric cardiologist at Children's Healthcare of Atlanta and director of the Aorta and Vascular Program. And on behalf of the GenTAC Alliance, I'll be presenting some of the thought process and data behind the use of medical therapy in pediatric patients with aortic disease. So we know from pathologic data that TGF-beta activity is upregulated in the aneurysmal aorta. And based on this, there were initially mouse trials that showed what would happen if we blocked that activity in mice. And traditionally, beta blockers had commonly been used for patients with Marfan syndrome, both for their physiologic effect to reduce blood pressure and heart rate, and they also were thought to have some degree of reduction of the rate of growth of the aorta. And based on mouse trials with anti-TGF-beta medications, which include angiotensin receptor blockers, there was an early trial with 17 patients who had really aggressive aortic dilatation, and this is just an example of one of those patients. So you can see the rate of growth that occurred while the patient was on beta blocker therapy. Then when they added irbesartan, they noted a stabilization of the size of the aorta. And based on this study, this led to a larger scale study. This trial was funded by the Pediatric Heart Network and was a trial that looked at comparing the effectiveness of standard therapy, atenolol at moderate dose, versus a low dose of losartan in pediatric patients across the United States. It was a multi-center blinded study, and there was a total of 608 patients that were enrolled. And essentially, therapies were found to be equivalent, with both producing a fall in the aortic Z-score over time. And one of the other things that came out of this study noted that when therapy was initiated at a younger age, it tended to have a more significant effect in the aortic root Z-score over time. Importantly, there were other trials that were being done as well in Europe and in adults, and these also showed that the use of angiotensin receptor blocker slowed the rate of aortic progression when compared to placebo, and that there may have even been an added benefit when they were added on top of beta blocker therapy. This looked at the COMPARE trial, again another larger trial in Europe, and looked at beta blocker versus beta blocker plus losartan over the course of 3 years. And on completion of the trial, 75 patients opted to continue losartan, and that group was compared to beta blocker therapy alone. And for those patients, there was a decreased risk of events seen in the losartan group, so both death, dissection, and the composite endpoint. So data is starting to really confirm a benefit to medical therapy. And most recently, another meta-analysis was completed that looked at individualized patient data and grouped all of the trials together. And that included over 1,400 patients with Marfan syndrome. So this is different than some other meta-analyses, which essentially look at the conclusions of different papers and then try to draw a main conclusion. This actually looked at patient-specific data and again demonstrated a benefit with angiotensin receptor blocker therapy. And the benefit was noted to show a reduction in the rate of change of the aortic Z-score by about 50%, which is quite remarkable. Now, as many of us who take care of pediatric patients are aware, thankfully the risk of aortic events in children overall tends to be fairly low. This was actually well demonstrated by a large group in Europe that looked at 460 patients with a median follow-up of 17 years and found only about a 5% risk of aortic event during that time period. Importantly, the bulk of those were actually prophylactic aortic surgery. There were only 2 incidents of dissection, and one of those occurred secondary to a motor vehicle accident. So in many cases, families will say, well, if my aorta is not enlarged now or not substantially enlarged now, then why do I need to take medication? So when approaching this discussion with a family about whether or not we should start medical therapy at a young age in a child who otherwise feel well, I can often quote to them that, we know medical therapy reduces composite endpoints of aortic dissection and death, but sometimes that's not quite as meaningful to some families. As a recovering engineer, I like math and often try to think about things in terms of numbers and equations. And so in my mind, if we think about a theoretical patient who, let's say we diagnose him at age 3, and we extrapolate, make a few assumptions about the rate of growth of the aorta based on historical data from prior papers, and assume that during early childhood we may have about 1 millimeter of growth per year, and then during adolescence that growth often increases, which is no surprise to those of us that see a lot of adolescents. And then often once skeletal growth is complete, the rate of growth of the aorta tends to slow down. And if we then make the assumption that medical therapy will reduce the rate of growth by about 50%, then you can see the effect on this on a patient. Looking at what happens if we don't start medication and the aorta grows at standard rate, then this patient would in theory reach the surgical threshold of 5 centimeters at age 30. If instead we said, hey, now that we know you have this, we're going to start medication at a very young age, and we start at age 3, you can see we really have a substantial effect and defer the aorta reaching 5 centimeters until age 74. Alternatively, if this medical therapy is started towards the middle of adolescence, a good bit of aortic growth has already taken place, and it only defers surgery to age 46. Interestingly, there is work being done by Dr. Morris and others out of Texas to try to develop patient-specific models where you could use their actual data points to try to plot this type of effect for them. So certainly we think going forward we may be able to provide even more compelling evidence about the benefits of medical therapy to patients and their families.